Meet Charlie, 67, a retired shipyard worker with a 40-year smoking history and long-standing COPD. He presents with worsening shortness of breath, harsh cough, and green sputum. Notice, at baseline, Charlie has a cough, fatigue, diminished breath sounds, and accessory muscle use. Barrel chest reflects chronic air trapping, and elevated red blood cells reflect long-term low oxygen. Today's dyspnea and purulent sputum suggest an exacerbation. A chest X-ray checks for pneumonia or pneumothorax, ABG for hypercapnia and acidosis, and a sputum culture for infection. Interpret. Chronic obstructive pulmonary disease is a progressive, largely irreversible airflow limitation caused by chronic bronchitis, emphysema, or both. Chronic bronchitis inflames the airways and increases mucus production, causing a chronic productive cough and recurrent infections. Emphysema destroys alveolar walls, merging them into larger damaged spaces that reduce surface area for gas exchange. The resulting loss of elastic recoil lets small airways collapse on exhalation, trapping air. Over time, this hyperinflates the lungs, flattens the diaphragm, and makes breathing progressively more labored. Each exacerbation causes lasting damage, and any respiratory virus can trigger one. Cigarette smoking is the most common risk factor. Respond. Treatment includes carefully controlled oxygen, target 88 to 92%, bronchodilators to open airways, corticosteroids to calm inflammation, and antibiotics for suspected infection. If Charlie is retaining CO2 or tiring, BiPAP eases his work of breathing. Oxygen must be titrated carefully, since low oxygen, not elevated CO2, has become his main drive to breathe. Long-term management includes smoking cessation, long-acting bronchodilators, corticosteroids, roflumilast to reduce exacerbation frequency, pulmonary rehab, vaccinations, and home oxygen. Diet should be high-calorie, high-protein, and moderate carb to limit carbon dioxide production. End-of-life discussions are often more appropriate than intubation and mechanical ventilation, since weaning is extremely difficult. Reflect. Improvement looks like a return toward baseline, manageable dyspnea, clear or white sputum, adequate energy, and oxygen saturations of 88 to 92%. Worsening can progress to respiratory failure or hypercapnia, drowsiness from rising carbon dioxide, treated with BiPAP. Charlie risks pulmonary hypertension and right heart failure. Summary. COPD is an irreversible mix of chronic bronchitis and emphysema, most often caused by smoking. Barrel chest and clubbing are classic chronic signs, and dyspnea and purulent sputum signal an exacerbation. Acute care relies on bronchodilators, corticosteroids, antibiotics, and oxygen. Chronic control relies on long-acting bronchodilators, corticosteroids, roflumilast to reduce exacerbation frequency, pulmonary rehab, vaccinations, and home oxygen. If you study to remember, you will forget. But if you study to understand, you will remember. Author unknown.